You're listening to Medscape's In Discussion series on Cardiorenal Metabolic Syndrome, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Nihar Desai. Dr. Desai is an associate professor of medicine and vice chief of the section of cardiovascular medicine at Yale University School of Medicine. Relevant disclosures can be found with the episode show notes on medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for you as healthcare professionals.
Hello, I'm Dr. Nihar Desai from the Yale School of Medicine. Welcome to Season 1 of the Medscape In Discussion Cardiorenal Metabolic Syndrome podcast series. Today, we're discussing novel therapies in CRM, focusing on the GLP-1 receptor agonists. Absolutely delighted to have Dr. Matt Cavender as our expert guest today. Dr. Cavender is an associate professor of medicine in the Division of Cardiology at the University of North Carolina School of Medicine and is director of cardiology clinical trials there. So Matt, welcome to the Medscape In Discussion podcast. We're so delighted to have you with us.
Thanks, Nihar. It's great to join you as well.
So Matt, there's been so much excitement, so much interest in the GLP-1 receptor agonists. I was thinking that maybe you could just start us off maybe with a very brief history on the development of this class of therapies and specifically kind of their development as, quote, diabetes medicines, if you will.
Sure. Well, the incretins first garnered attention in the world of endocrine physiology, actually. Back in the 1960s, people realized that if you gave a patient oral glucose, the insulin response was much greater than if you gave someone IV glucose. And so that made people think that there had to be something in the gut that was going on that increased the insulin response much more than just what was coming through the intravenous route. And so the first incretin actually to be sort of identified was in the 1960s, and it was this glucose-dependent insulinotropic polypeptide, which is a word that we shorten now to GIP, and that's going to become relevant probably later on as we talk about some of the novel therapies. So that was really the first peptide that was identified as one of the incretins. It wasn't that much longer, probably about a decade later, that glucagon-like peptide, which is also in the incretin family, was further identified as kind of another of this incretin family. And this, it turns out, this GLP-1 was a much more potent peptide and had a much more dramatic effect than the initial GIP. And it turned out that this GLP was secreted from the terminal ileum almost within minutes of when food kind of hits the GI tract. This GLP-1 gets released into the system. And so it has a lot of different effects. It increases insulin, it decreases glucagon, it makes your body uptake glucose much more quickly. And then in some good physiologic effects, it actually delays gastric secretion and makes you feel full a lot sooner. And so these were some of the physiologic effects of GLP-1 that got identified pretty early on in the process, which then led people to think, hey, this may be of utility from a pharmacologic standpoint.
Really fascinating. And to think about kind of the pathophysiology and some of the initial observations that guided the development of these therapies. And then maybe take us, kind of almost in sequence then. Tell us about some of the early clinical development kind of on the pharmaceutical side and what we learned about these drugs kind of in that early context.
So in 2005, actually, the first GLP-1 receptor agonist was approved by the FDA. It was exenatide, and it was an injectable GLP-1 receptor agonist, of which all of them to date, with one exception, are. It was injectable. It was used for patients and approved for patients for glucose control, for control of type 2 diabetes, to reduce hemoglobin A1C. And that was where the early interest was. Now, if you'll remember back to 2005, there was a lot going on in the endocrinology space around that time period. It was just a couple years later that there was a very famous meta-analysis, which was published in the New England Journal by Steve Nissen and Kathy Wolski, looking at rosiglitazone. Now, rosiglitazone was a TZD, had nothing to do with sort of GLP-1 receptor agonist. But what Steve Nissen showed in this meta-analysis was if you took a lot of clinical trials, many of them of very short duration and of very healthy patients, we can talk a little bit about that meta-analysis in maybe a different podcast. But he found and described a higher risk of cardiovascular events in those patients who were treated with rosiglitazone. This came on the heels of another dual PPAR agonist, a muraglitazar, actually underwent an FDA AdCom and was approved, but never reached the market because of some adverse events that circled out. So there became a lot of interest and a lot of worry that actually medicines that treated diabetes may actually be increasing cardiovascular risk. And so in 2008, the FDA released a guidance document describing the process by which diabetes drugs would need to demonstrate that they were safe from a cardiovascular standpoint. And so it was kind of in that setting that there were a variety of clinical trials that were developed, most of which were not actually developed to show that these drugs were effective, but were actually developed to show that they didn't increase harm. There were a variety of these from the GLP-1 receptor agonist standpoint, but the one that probably really increased this class of medications to the forefront was liraglutide in the LEADER trial. And so that was actually published some years later in 2016. And it showed for the first time convincingly that GLP-1 receptor agonists actually reduce the risk of cardiovascular events.
That really sets up the whole story, actually, right, of the SGLT2 inhibitors and now also the GLP-1 receptor agonists. And so that backdrop, if you will, and then the need to show cardiovascular safety, and then to everyone's delightful surprise, cardiovascular benefit has now transformed. And obviously, you're going to tell us about all the details and the true impact on our cardiorenal metabolic patients. But, quote, these diabetes drugs have transitioned now into cardiorenal metabolic powerhouses. And much of it goes back to that history that you kind of, walked us through. And so now I want to get your sense as a practicing cardiologist, a clinician, someone who's in the hospital and in the office setting taking care of patients. And we've talked in prior segments of this podcast on the prevalence of cardiorenal metabolic conditions, and the influence of social determinants, how these things are coming together to really potentially even accelerate the prevalence of cardiorenal metabolic conditions. And so, against that backdrop, what have we learned about the efficacy and safety of the GLP-1 receptor agonists, not just for the patients with diabetes, though that's where the whole story started, but then for our patients with cardiorenal metabolic conditions? And so maybe take us through that story kind of in this next segment here.
That story really does start with the LEADER trial. And, liraglutide was the first to demonstrate this efficacy. And, it was a study of almost 10,000 patients, all of which had type 2 diabetes. And then patients had to either have multiple risk factors for atherosclerosis or known atherosclerotic disease. And there was a small but real benefit, about a 15% risk reduction in the overall risk of cardiovascular events in this patient population. That then led people to say, well, what if we could improve on the GLP-1 receptor agonist? What if we could, make it more potent, more powerful? What if we could change the way that we dosed it? And so then there have been a variety of different GLP-1 receptor agonists which have come through that, looking at these therapies in people mostly with risk factors, with, for example, dulaglutide showing a cardiovascular benefit in patients who have type 2 diabetes and risk factors, patients with atherosclerotic disease, specifically with liraglutide, but then also with semaglutide, which is now a more potent GLP-1 receptor agonist, both in the subcutaneous form, like the majority of our GLP-1 receptor agonists, but also now in an oral form that you can take, which will be the drug which is being studied in the SOUL trial. In addition, it's expanded the population. So now, not only have we looked at this drug in patients with type 2 diabetes, but now just recently at the American Heart Association meeting in the fall of 2023, we had the results of the SELECT trial. The SELECT trial was really a landmark trial. It was led by Mike Linkoff from the Cleveland Clinic, who looked at semaglutide in over 17,000 patients, all of which had obesity. Obesity was defined as a BMI of greater than 27, but more importantly, none of these patients had actual diabetes. So, in contrast to some of the prior studies of GLP-1 receptor agonists looking specifically at type 2 diabetes and atherosclerotic disease, this opened up kind of a whole new world, if you will, of those patients who had obesity. So they were certainly at risk of cardiometabolic disease. And you could argue have cardiometabolic disease, but just didn't have diabetes. In the SELECT trial, there was a resounding benefit with semaglutide, not only in terms of our typical kind of MACE endpoint of cardiovascular death, MI, and stroke, but actually on cardiovascular death. It made a dramatic endpoint or impact on the outcomes in this kind of new population.
I think the select findings then really highlight and illustrate what the cardiorenal metabolic patient is and the kinds of impact that therapies like this can have. And so I couldn't agree with you more that Select was so exciting and I think opened up a whole new avenue to address and actually improve outcomes for our patients with cardiorenal metabolic conditions. So now whether they have diabetes, whether it's obesity, whether it's, renal dysfunction, there's a role for these therapies there. I guess one other kind of disease state that I'd like to get your thoughts on then is another what has been historically a very challenging clinical condition to manage with very, very few therapies. And that is heart failure with preserved ejection fraction. Now, we've seen very impactful data for the SGLT2 inhibitors for those patients and improvements in cardiovascular events and important reductions there. But then recently, we're just starting to get some data looking at the GLP-1 receptor agonists for those patients with preserved ejection fraction heart failure. You want to tell the audience a little bit about those kind of data?
Yeah, but maybe even before I get into the heart failure with preserved ejection fraction, it would be helpful to sort of highlight the effects of GLP-1 receptor agonist on the heart directly. We know that these agents have direct myocardial effects. You can see when you give these medications that actually heart rate increases. So there's clearly a cardiovascular effect that these drugs have on the myocardium. And in fact, there's actually been studies, kind of neat studies, physiologic studies, where people have actually looked at cardiac output with infusions of GLP-1. And actually, when you give someone an infusion of GLP-1, the cardiac output actually increases. That led to some thought that these drugs may be helpful in people with heart failure. It hasn't actually panned out. If you look at heart failure with reduced ejection fraction, there was a fairly small study. This is now probably 10 years ago. It looked at people with pretty advanced heart failure, actually. It was an NHLBI study where they looked at GLP-1 receptor agonists in people with fairly advanced heart failure, and it actually increased the major adverse events. It actually worsened heart failure. So that put a little bit of pause on sort of the potential benefit of these agents. But since that time, there's been more and more interest specifically looking at heart failure with preserved ejection fraction, as you sort of highlighted. One of the challenges with heart failure with preserved ejection fraction is that it's really a pretty heterogeneous group of people. There's the people that have obesity and shortness of breath and some of the diastolic dysfunction related to that. There's people who have longstanding hypertension. There's people who have longstanding chronic kidney disease. Those disease processes are probably all not the same. Just recently, actually, Mikhail Kosoborov actually presented data from some small randomized trials, specifically looking at the effects of GLP-1 receptor agonists in heart failure with preserved ejection fraction, both in patients with diabetes and then in a broader population. And it was a program that was called the STEP HFpEF program. And there were two separate trials. They've actually been pooled now into one overall study that was actually just published a couple weeks ago in the Lancet. And what they found overall was that when patients with heart failure with preserved ejection fraction, irrespective of whether they're diabetes or not, were started on GLP-1 receptor agonists, patients felt better. And the way they assessed it in this particular trial was with the Kansas City Cardiomyopathy Questionnaire. They actually used a specific type of it, the Clinical Summary Score, which is one of the kind of subtypes of the KCCQ. And what they found were really clinically meaningful improvements in how patients felt after starting these medications. And so there's been a lot of discussion around that, whether that really is sort of a sign of whether that was directly impacting heart failure per se, or whether it's more just a fact that these patients lost weight on these medications. And so, do they just feel better and less short of breath because they lost weight? It's a little bit hard to say, but what I will say is if you pool all the clinical events together, there were less heart failure events in those patients who were treated with GLP-1 receptor agonists, which I think is supportive. Of course, the KCCQ is a very well validated patient quality of life score, which has been very well correlated to outcomes in heart failure. So I think these two pieces of data suggest that GLP-1 receptor agonists probably do have a role in improving at least how patients with HFpEF feel.
Yeah, Matt, I think you're so right about that, and I think oftentimes we get caught up in what's the exact mechanism and how is the benefit tied to weight loss? Is the benefit tied to some direct kind of effect on the vasculature or the hemodynamics or some other effect? And I think we're all very anxiously awaiting the additional clinical studies that will be coming. I want to sort of shift gears and kind of ask you on that front. You already talked to us about Select and kind of all the excitement and the really important findings from Select. As you look at the field, what are you sort of most looking forward to? Are there studies or things that you particularly want to highlight for our audience to say, hey, this is something really important, or this is a study that I'm really interested in?
I don't know that there's ever been an area of pharmacology in which there has been more excitement and interest than the incretin field. There are no telling how many different compounds which are at various stages of being developed right now. The ones that I'm probably most interested in, I think, are probably two. The first is the Surpass cardiovascular outcomes trial. That is with tirzepatide. Tirzepatide is a very potent GLP-1 receptor agonist. In fact, you could argue it's probably the most potent GLP-1 receptor agonist that we have out there, at least by some metrics. It's being compared to dulaglutide. Of course, dulaglutide has been shown to also improve cardiovascular outcomes. That's going to be really fascinating because, as opposed to prior studies, which have all been compared to placebo, you now have an active comparator arm that one could argue is a very effective therapy. And so we're going to see now, is there benefit above and beyond with even more potent agents as we get into understanding the relationship between potency and outcomes? So I think that's one that I'm really excited about. Not exactly sure when we'll see those results. At least what's been publicly available is that sometime probably in 2025. It will all depend on how that clinical trial goes. The other one that I think am personally involved with, and so I'm very excited to see the results, is with an oral GLP-1 receptor agonist. The SOUL trial is taking patients with atherosclerotic disease and type 2 diabetes or chronic kidney disease and randomizing them to oral GLP-1 receptor agonists. Now, the oral medication, as opposed to the injectable ones where you take, once a week, the oral ones you have to take every day. And you also have to take it on an empty stomach. So it's the first thing you take in the morning. You can't even have your morning coffee. You have to take this GLP-1 receptor agonist first. There's been a lot of reasons to think that having an oral alternative will be more patient friendly. Although you could argue that a once weekly injection is actually pretty patient friendly. But that clinical trial will be really important because it's going to be the first oral GLP-1 receptor agonist. We have at least a little bit of data from the phase 2 studies that suggest that it also is effective from a cardiovascular outcome standpoint, but we'll see in a large clinical trial. And then there's a variety of different combinations. We mentioned some of the different members of the incretin family. We now have GIP, GLP-1 receptor agonist. We now have triple agonist with GIP, GLP, and then glucagon receptor. We also have amylin analogs with cagrilintide being combined with semaglutide, CagriSema. So we have a variety of different combinations of medications that are all getting combined. And it's going to be interesting to see which one of these, if any, becomes the one that's clearly the best.
I guess the other dimension that comes to mind here is, so we have a class of therapies, many novel therapies, and several existing therapies that have shown very important clinical benefits. And obviously, there's so much more to learn and so much more to understand about the potential impact of these therapies for our CRM patients. With that spirit of so much excitement, so many new therapies, so many studies, and rightfully so, I think we're all there with you. Maybe give us your sense on the adoption of these therapies in practice. How has that gone? What's been your experience, or what have you heard from colleagues? I think one of the things that we all struggle with is that we continue to have this divide between evidence and practice, and that we have to continue to do better at enabling providers and obviously patients to partner together to get the therapies that they think could have important positive impact for them.
The gap between evidence generation and implementation has probably never been greater than what we've seen with the GLP-1 receptor agonist. Adam Nelson, who's a cardiologist in Australia, looked at the PCOR sites here in the United States, which are all, very high quality sites that have electronic medical records that you can go in and try to really get very accurate data on demographics and medication use. And granted, the data is a little bit dated, but back from 2018. But remember, that's post leader. Multiple studies had been shown to be beneficial at this point. And in patients who qualified for a GLP-1 receptor agonist in the PCOR net sites, less than 5% of patients were actually on a GLP-1 receptor
Wow.
agonist, which is
Wow.
incredibly low, right? In fact, just
Wow.
last week, I was going through some of the data from one of our clinical trials. Now, granted, not all the patients in that clinical trial would have qualified for a GLP-1 receptor agonist, but a lot of them actually would have. We had less than 10% utilization of GLP-1 receptor agonist in our clinical trial. So these medications clearly been shown to be beneficial. Patients want to use them, but they're not really making their way out to clinical practice. And I think there's a variety of reasons for that. I think part of it is the clinical inertia piece that we talk about. Part of it is restrictions around cost. I work for the University of North Carolina. I'm a state employee. Our state healthcare plan basically said we are not going to cover these agents universally because essentially, if we do that for everybody who has an indication for this, it will double our healthcare expenditures, and we just can't afford that as a health insurance plan. So I think that's some of the challenges that we have to figure out about how we sort of use that. We actually looked at this in the Coordinate Diabetes trial. This was a trial that we did in cardiology sites. So these are all cardiologists, and we went to them and we said, okay, how can we increase the utilization of evidence-based therapies for patients with diabetes? Make sure they're on a high-intensity statin. Make sure they're on an ACE or an ARB, an SGLT2 inhibitor, or a GLP-1 receptor agonist. And then we randomized them to either sort of an intervention, which was a multifaceted intervention that had to do with, education, access to kind of experts, people who were well-versed in using these medications and could help clinicians as they tried to do it. And then probably more importantly, a scorecard where we actually gave people audited feedback on, okay, here are the proportion of your patients who are on these medications. And even with that intervention, there was overall good news. We increased all three therapies from about 15% up to about 40%. So there was a significant improvement with this intervention. It went up by about fourfold, 25%. But the glass half empty of that is that these three therapies we still got implemented in less than half of the people who were potentially eligible. So we've got to figure out how to do a better job of that. I think it starts with education. So I appreciate the job that you're doing on this podcast of letting people know about these medications, and then, more importantly, how to use them, how to start them. And maybe that'll be a good one to talk about for another podcast in season 2, is to come back and think about some of the practical aspects of, like, okay, I know the evidence base, I understand they work. How do I actually do it? Because that's really where the rubber meets the road.
Yeah, Matt, what a great discussion this has been. I mean, you've sort of taken us through a lot in a relatively short period of time, from the development, the initial discovery of this class of therapies, some of the early clinical trials, a lot of the newer clinical trials, and what the frontier kind of looks like. And then I think you perfectly set up. We're going to actually do a segment later on in the series on implementation science, and really highlight, what are some of the really innovative things that are happening out there, because that sort of final piece of the puzzle really has to come together if we're going to realize all the real benefits of therapies like the GLP-1 receptor agonists for our patients with cardiorenal metabolic syndrome. And so, Matt, I really want to thank you for joining us and being our guest today and for a wonderful discussion.
Thanks, Nihar. I really appreciate the invitation, and it's great talking with you as well.
So today we discussed novel therapies in cardiorenal metabolic syndrome, focusing on the GLP-1 receptor agonists with our guest, Dr. Matt Cavender. I'll just make a note for the audience to please take a moment to download the Medscape app to listen and subscribe to this podcast series. Thanks again for joining us. This is Nihar Desai from the Yale School of Medicine for the Medscape in Discussion Cardiorenal Metabolic Syndrome podcast series.
Thanks for listening to Medscape's In Discussion Cardiorenal Metabolic Syndrome podcast series with our host, Dr. Nihar Desai. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out medscape.com or the Medscape app for show notes, links, and more information on cardiorenal metabolic syndrome.